Did you know that up to 32% of claims against physicians for this specific condition relate to inappropriate delays in diagnosis? It's a scenario where minutes, literally minutes, can mean the difference between full recovery and, well, devastating permanent consequences. We're talking about compartment syndrome. Welcome to the deep dive. This is the show that takes your stack of sources, articles, research, maybe your own notes, and really pulls out the absolute most important nuggets of knowledge. We aim to cut through the noise, help you get properly well informed, fast, with those surprising facts and insights that hopefully stick with you. Today, we're taking a really deep dive into the complex world of compartment syndrome, drawing on the materials you've provided us. And guiding us through this critical topic is our expert guest today, Prof. Mo Imam. He's known for his ability to synthesize complex medical information into, well, practical, understandable insights for professionals like you. Professor, it's a real pleasure to have you with us.
Thank you. It's a pleasure to be here. The source material you've shared, it provides an excellent foundation for understanding this condition. It really is, as you said, a race against time in those acute cases.
Absolutely. And look, before we delve right into the specifics, let's maybe set the stage with a quick rapid-fire round, just based on the core concepts from the sources. First off, Prof, if you had to define compartment syndrome at its most fundamental level, what would you say it is?
Right. So at its core, compartment syndrome is, well, it's a condition caused by dangerously high pressure building up within a confined space. Usually that's a muscle compartment in the limbs, arms, legs. And this pressure, it becomes so elevated that it actually restricts blood flow to the muscles and nerves within that compartment.
High pressure restricting blood flow. Okay, that sounds critical. Now, the sources, they distinguish between two main types, acute and chronic. What's the single most important difference someone needs to grasp immediately between those two?
Okay, the critical difference, I suppose, really lies in their onset and cause. Acute compartment syndrome is, sudden. It's a severe medical emergency, often triggered by major trauma, a bad break, perhaps. The pressure rises rapidly and it stays high. Chronic compartment syndrome, now that's different. It develops more gradually. It's linked to repetitive physical exertion, exercise usually, and typically it resolves when you stop and rest.
Sudden emergency versus activity-related and self-resolving with rest, right? That's a key distinction indeed. And finally, you mentioned a race against time. The phrase time is tissue seems so applicable here based on the sources. What exactly are we racing against? What's really at stake?
You're fundamentally racing against irreversible tissue damage, tissue death, actually. When the pressure hits a critical level, the lack of oxygenated blood, well, it causes muscle and nerve cells to start dying. And that cell death, it's often permanent. It can lead to devastating long-term consequences. So every moment is crucial. You need to restore that blood supply before the damage becomes irreversible.
Okay, right. Let's properly unpack this critical topic then based on your source material. As you've highlighted, the sources categorize compartment syndrome primarily into these two types, and each has very different implications, doesn't it, for both presentation and how you manage it. We'll start by defining those types in more detail, maybe look at their typical causes, and then delve into that, well, fascinating, albeit quite concerning, underlying physiological process described in the material. So, Prof, let's start with acute compartment syndrome. What exactly defines this medical emergency according to the sources you reviewed?
Okay, acute compartment syndrome, or ACS. That's the more dramatic and urgent form, definitely. The sources consistently describe it as a condition marked by a rapid, significant increase in the interstitial pressure. That's the pressure within a closed space, defined by bone and the tough fascia surrounding the muscles. This pressure rise is often triggered by a severe injury. Think fractures, particularly long bones like the tibia in the lower leg or the forearm bones, or perhaps a crush injury. The fundamental problem is this sudden pressure hike. It compromises the blood flow, particularly the outflow in the veins and capillaries. And if it's not addressed quickly, it can lead to severe irreversible damage. We're talking muscles and nerves within that compartment. And the onset of symptoms, typically sudden and quite intense.
So the severity and the speed are defining features. The sources also lay out some key clinical signs to watch for with ACS. Beyond just that severe pain, what are those other crucial indicators mentioned?
Yes, the sources detail several critical clinical signs. They tend to manifest relatively quickly in ACS. While pain is absolutely paramount, patients might also experience paresthesia. That's that odd sensation, tingling or numbness. There can be pallor as well. The limb might look unusually pale, lose its normal color. It might feel cold too. A late sign, and a very concerning one, is paralysis. That indicates significant nerve or muscle dysfunction has already happened. And, of course, underpinning all this is the objective finding, elevated intracompartmental pressure.
Right, that pressure measurement. It sounds key for actually confirming it. The sources specify a critical threshold for this pressure, don't they? What's the number that's often used to guide diagnosis and, well, intervention?
That's correct. As highlighted in the material, a common threshold indicating a critical level of pressure is an absolute intracompartmental pressure, or ICP, of 30 millimeters of mercury, or greater. Reaching or exceeding this pressure is a strong signal that the tissue is at risk of ischemia, meaning lack of blood flow, and it's often used to recommend surgical intervention, like a fasciotomy.
And the sources are pretty clear about the consequences of missing this or delaying treatment.
Absolutely. The message from the sources is quite stark, actually. Delay in treating ACS can lead to permanent muscle contractures. That's where the muscle tightens up permanently. Also, irreversible nerve damage resulting in sensory loss or paralysis. And in the most severe untreated cases, it can even necessitate amputation of the limb. This is precisely why immediate recognition and intervention are absolutely critical.
That paints a very clear picture of the acute emergency. Now let's turn our attention to the other type, chronic compartment syndrome, often called exertional compartment syndrome. How does this differ in its presentation and its underlying causes according to the source material you looked at?
Chronic compartment syndrome, or CCS, it's quite different in its nature, yes. Unlike the sudden onset of ACS, CCS develops more gradually over time, and it's intimately linked with repetitive physical activities or strenuous athletic exertion. The crucial difference in presentation is that the symptoms of CCS are typically only experienced during the specific physical activity that triggers the pressure buildup, and, characteristically, they subside or resolve completely with rest.
So someone might feel symptoms while, say, running or swimming, but feel perfectly fine when they stop or are just resting.
Precisely. That's exactly it. The sources note that individuals with CCS commonly report symptoms like aching, burning, or cramping pain. Sometimes tightness or swelling, too, localized to the affected muscle compartment. This discomfort usually starts within a predictable time frame after beginning the activity maybe 10 to 30 minutes in, and then significantly eases or just disappears within a few minutes or hours of stopping.
And is the risk of permanent damage the same as with the acute form, or is it less severe?
Generally, no, it's less severe in that respect. The sources indicate that CCS typically does not result in permanent irreversible tissue damage in the same way that acute compartment syndrome does. However, while it's not usually limb-threatening, it can significantly impair an individual's ability to participate in their chosen activity. It limits performance, endurance, because the symptoms are reliably brought on by exertion.
And how is the management different then, based on what the sources say?
The initial management approach for CCS, as described in the sources, is primarily non-surgical. It focuses on activity modification, so altering or reducing the specific activities that trigger the symptoms. This might involve changing training regimens, maybe using different footwear, or adjusting technique, things like that. If these non-surgical measures prove ineffective, if they don't allow the individual to get back to their desired activity level, then surgical intervention might be considered. That's usually a fasciotomy, similar to that for ACS, but it's performed electively, not as an emergency.
Okay. The sources mention that compartment syndrome can affect various areas of the body. While the mechanism is similar, where is it most frequently encountered? For both the acute and chronic forms.
Well, theoretically, any compartment in the body could be affected, but the sources are quite consistent. They state that the lower leg is by far the most common site, especially for CCS, the chronic form. The forearm is the second most common location, and that's for both acute and chronic forms. Other sites, like the thigh, the foot, the gluteal region, they can also be involved, but it's less frequent. It's really down to the anatomy of these areas. They have relatively tight fascial coverings, which makes them particularly susceptible to pressure increases.
Right, that makes sense. Let's dive a bit deeper into the triggers and risk factors now, particularly for that critical acute form. Trauma seems to be the overwhelming cause, doesn't it?
Trauma is indeed the predominant precipitating event for acute compartment syndrome. The sources place particular emphasis on high-energy trauma. Fractures of long bones are cited as a major risk factor, especially those involving the tibia, that's the larger bone in the lower leg, and the bones of the forearm. The incidence rate of compartment syndrome in tibial fractures alone, as noted in the material, is remarkably high. It's quoted as ranging from 7% up to 11%.
That statistic for tibial fractures is quite striking, actually. What other specific types of trauma or mechanisms of injury are highlighted in the sources as being particularly high risk?
The sources list several other significant traumatic causes. These include severe crush injuries, obviously causing extensive muscle damage and swelling. Also, gunshot wounds and stab wounds, which can directly injure vessels and tissues within a compartment. Motorcycle crashes are mentioned frequently, as are pedestrian injuries, resulting from being struck by a vehicle. These mechanisms typically involve significant force that disrupts tissue and can lead to bleeding and edema, swelling within that enclosed compartment.
There's a particularly alarming statistic in the sources regarding combined injuries. Could you elaborate on that one?
Yes, the material provides a very telling statistic there. The risk of developing compartment syndrome is significantly elevated if a patient sustains combined arterial and venous injuries within the affected limb. So damage to both the arteries bringing blood in and the veins taking it out. The sources report that in such cases, the incidence rate can jump dramatically to 41.8%, almost half. Now, you contrast that sharply with rates of maybe 5.9% for open fractures or a mere 2.2% for closed fractures without that vascular compromise. It really highlights how profoundly impaired blood flow, both in and out, escalates the risk.
Wow, that really underscores the complexity, doesn't it? And how different injury patterns affect the likelihood. Beyond direct trauma, are there any non-traumatic causes for acute compartment syndrome mentioned in the sources?
Yes, the sources do broaden the scope beyond just mechanical trauma. Non-traumatic causes of ACS mentioned include complications arising from medical interventions or conditions. Examples given include complications from drug overdoses, particularly with substances that cause muscle breakdown, that's rhabdomyolysis, or instances where intravenous fluid infiltrates into the tissues, causing substantial local swelling. The sources also reference historical cases, like those described by Volkmann way back, where external compression from excessively tight bandages, splints, or casts actually contributed to the development of compartment syndrome.
It's interesting, isn't it, how even seemingly benign things like tight dressings could potentially be a trigger? Shifting focus back to the chronic form again, what are the typical risk factors associated with exertional compartment syndrome?
For CCS, the risk factors are, well, as the name suggests, primarily related to physical activity. High-impact, repetitive activities and intense endurance exercise are the common culprits. This is why athletes, particularly runners, cyclists, or swimmers, are frequently affected. But also, individuals in physically demanding occupations that involve prolonged repetitive motions of the limbs can also be at risk.
Are there any other specific patient groups or conditions that the sources identify as being potentially more susceptible?
The sources do mention that individuals with certain pre-existing conditions, particularly blood disorders like hemophilia, may be at increased risk. Their inherent predisposition to bleeding and the difficulty in controlling bleeding can lead to hematoma formation, a collection of blood within muscle compartments, which subsequently causes elevated pressure.
Recognizing these diverse risk factors seems absolutely crucial then for early suspicion and hopefully preventing complications. The sources make a clear link here.
They do, absolutely. Maintaining a high index of suspicion based on understanding these risk factors, it's paramount for both acute and chronic forms. For ACS, it prompts immediate evaluation. For CCS, it helps differentiate it from other causes of exercise-induced leg pain, like shin splints or stress fractures. Early recognition is fundamental. It's what allows timely management to be initiated, preventing those long-term consequences, permanent muscle weakness, chronic pain, disability, which the sources strongly associate with delayed treatment.
Okay. The sources delve into the underlying pathophysiology, how this dangerous pressure buildup actually occurs at a physiological level. Could you walk us through the mechanism described? What's actually happening inside that muscle compartment?
Right. The core mechanism, as detailed in the sources, it begins with an increase in the interstitial pressure within that confined space, the osteofascial compartment. This increase can be due to various factors we've discussed: bleeding from a fracture, swelling or edema from trauma, or fluid infiltration, or even external compression from a cast. As this interstitial pressure rises, it eventually exceeds the pressure in the venules and capillaries, the small veins.
So it gets higher than the pressure pushing blood out.
Precisely. This gradient inversion, as it's called, compromises or completely prevents venous outflow from the compartment. Blood can still flow into the compartment via the higher pressure arteries, but it can't get out effectively via the veins. This trapped blood and fluid, held within the rigid fascial boundary, causes the pressure within the compartment to rise even further. It creates a vicious cycle, really. Increased pressure impedes venous outflow, which causes more swelling, which further increases the pressure.
And what happens next in that cycle? How does the actual tissue damage occur?
Well, as the compartment pressure continues to rise, it eventually exceeds the arterial capillary pressure. the pressure in the tiny arteries feeding the tissue. At this point, blood flow into the compartment is also significantly diminished or, in severe cases, completely ceases. This leads to ischemia, a severe lack of oxygen and nutrients in the muscles and nerves within that compartment. The sources explain that the muscle cells, being highly metabolically active, they just cannot tolerate this oxygen deprivation for long. Metabolic processes break down, and if perfusion, blood flow, isn't restored promptly, it leads to irreversible cellular injury and eventually tissue necrosis, tissue death. The nerves are also highly susceptible to ischemia, which affects their function very quickly.
So this physiological cascade explains exactly why time is tissue. The lack of oxygen directly kills the cells because the sort of pressure cooker environment you described just stops the blood flow.
Exactly. Understanding this process, the initial pressure rise, the venous compromise, the subsequent arterial compromise, and that resulting ischemia leading to cell death, it clarifies the extreme urgency of acute compartment syndrome and why rapid restoration of perfusion is paramount. This mechanism is what underpins the severe symptoms we see and the potential for permanent damage.
Now that we have a solid understanding of the what's and the how, the types, causes, and that physiological cascade of pressure buildup, let's pivot to the critical phase. How do we spot the signs, make a definitive diagnosis, and manage this condition effectively? All based on your provided source material, of course. Preppy, you've already highlighted disproportionate pain as a key symptom. Let's revisit that. What makes this pain so distinctive and concerning, especially in acute cases?
Yes, the sources are quite emphatic about the nature of the pain in acute compartment syndrome. It's described as severe, deep, constant aching, burning, or cramping pain, typically localized to the affected compartment. What makes it a critical red flag is that it's characteristically disproportionate to the visible injury. So a relatively minor-looking injury might produce excruciating, unrelenting pain. Crucially, this pain doesn't ease with typical pain relief measures, even strong opioid analgesics like morphine, and it often worsens over time. A particularly sensitive sign mentioned frequently in the sources is severe pain experienced when the muscles within the affected compartment are passively stretched, so stretching them gently causes intense pain. That passive stretching test sounds like a vital bedside maneuver then. You also mentioned the classic 5 Ps. Can you outline those again for us, detailing what each P signifies as described in the sources?
Certainly. The 5 Ps serve as a useful clinical framework, a sort of mnemonic. Although it's important to note they don't all appear early or reliably in every single case. Based on the sources, the 5 Ps are, first, pain. As we discussed, severe, disproportionate, constant pain exacerbated by passive stretch. This is often the earliest and most reliable sign, especially in patients who can communicate clearly. Second, pallor. The affected limb or the skin over the compartment may appear pale due to reduced blood flow. It might also feel cool to the touch compared to the other limb. Third, paresthesia. This refers to altered sensation tingling, numbness, or pins and needles. It indicates ischemia affecting the sensory nerves. This is often an earlier sign than motor deficit than weakness. Fourth, paralysis. Weakness or inability to move the muscles in the affected compartment. The sources state that paralysis is a late sign, indicating significant nerve and muscle damage has probably already occurred. And fifth, pulselessness. The absence of a palpable pulse distal to the affected compartment, so further down the limb. The sources stress that this is a very late and often unreliable sign of compartment syndrome itself. It frequently suggests a concurrent major arterial injury, rather than just isolated compartment syndrome.
Okay, so the pain and paresthesia are often earlier indicators, while pulselessness and paralysis are quite late and suggest potentially more severe or complex issues are going on. Are there other physical signs mentioned in the sources that someone might look for?
Yes, besides the 5 Ps, the sources also highlight physical examination findings. Things like the affected compartment feeling noticeably tense, swollen, and firm, or even woody upon palpation, especially when compared to the unaffected limb.
And the sources mention a particularly concerning development in the later stages of acute cases, a potential decrease in pain. Why is that not a good sign at all?
Yes, this is a critical point. It really underscores the danger of delayed diagnosis. While a decrease in pain might initially seem positive, the sources explain that in late-stage acute compartment syndrome, it can actually signify that the nerves affected by prolonged ischemia are dying. They're losing their ability to transmit pain signals. So if the pain is going away because the nerves are becoming non-functional, it indicates severe, likely irreversible nerve and muscle damage is occurring. This should trigger immediate action, certainly not reassurance.
That's a vital piece of information for anyone assessing patients in these situations. The sources emphasize the need for a high index of suspicion, particularly for healthcare providers. Why is this vigilance so crucial in the clinical setting?
Maintaining a high index of suspicion is absolutely paramount, especially in any patient who has sustained trauma, particularly fractures or crush injuries or patients with severe limb pain that seems out of proportion to the apparent injury. The sources highlight that clinical assessment is often the starting point, and recognizing these early signs, the disproportionate pain, pain with passive stretch, maybe paresthesia, is essential to prompt further objective investigation. This vigilance, it's really the first line of defense against the devastating permanent damage that can result from delayed diagnosis and treatment. And remember that statistic we opened, with up to 32% of claims related to diagnostic delays. This underscores the real-world consequences of missed or delayed recognition.
That really brings us to the definitive step in diagnosis then. While clinical signs raise suspicion, what do the sources state is the gold standard for confirming the diagnosis of compartment syndrome, especially in maybe ambiguous or acute cases?
According to the sources, the definitive diagnostic method for confirming acute compartment syndrome is the direct measurement of intracompartmental pressure, the ICP.
How is that pressure measurement actually performed, and what specific readings are significant, perhaps beyond the 30 millimillig threshold you mentioned earlier?
Okay, so ICP measurement involves inserting a needle, or sometimes a specialized catheter, directly into the muscle compartment suspected of having elevated pressure. This allows for a direct reading of the pressure within that space. The sources mention devices like the Stryker manometer or a manometric IV pump system being used for this purpose. Though they do note there can be some variability and potential inaccuracies depending on the technique and the specific equipment used. It needs to be done carefully. A pressure reading of 30 millimeters of mercury or greater is, as we discussed, widely considered a critical threshold for contemplating surgical intervention. However, the sources also introduce another crucial metric, one that accounts for the patient's systemic blood pressure, the delta pressure.
The delta pressure, how is that calculated and why is it important?
Right, the delta pressure. It's calculated by subtracting the intracompartmental pressure,
Yeah.
the ICP, from the patient's diastolic blood pressure, the DBP. So delta P equals DBP minus ICP. The rationale here is that it provides a measure of the perfusion pressure gradient, basically the difference between the pressure pushing blood into the tissue, which is related to diastolic pressure, and the pressure resisting that flow, which is the ICP. The sources highlight that a delta pressure of 30 mmHg or less is a significant indicator of insufficient tissue perfusion. It suggests a risk of irreversible damage, particularly if it's sustained over a couple of hours. So it's not just the absolute ICP, but the pressure relative to the patient's own blood pressure that really matters for perfusion.
That adds a helpful layer of nuance to the diagnosis, doesn't it? So clinical suspicion leads to pressure measurement. What about imaging studies? What role do things like MRI or other techniques play according to the sources?
Imaging studies generally play a supporting rather than definitive role in the diagnosis, particularly in acute settings where time is absolutely of the essence and direct pressure measurement is really key. However, for chronic compartment syndrome, or in cases where the diagnosis is less clear, or perhaps differential diagnoses need to be ruled out, imaging can be very helpful. The sources mention magnetic resonance imaging, MRI, as a valuable tool. MRI can show anatomical detail of the muscle compartments and can reveal signs like muscle edema, swelling, or signal changes that might indicate injury or ischemia. For CCS, the chronic form, dynamic MRI performed at rest, then during exercise, and after exertion can sometimes demonstrate changes in muscle size or signal that correlate with the patient's symptoms.
Are there any newer or maybe less common diagnostic techniques mentioned in the material?
Yes, the sources briefly touch upon some emerging or alternative diagnostic techniques. Near-infrared spectroscopy, NIRS, is mentioned as a potential non-invasive tool. It can estimate tissue oxygen saturation and blood flow, offering insights into perfusion without needing needles. Infrared imaging, which measures skin temperature changes, is another technique listed as a potential indirect measure of blood flow, possibly useful for early detection. Additionally, electromyography, or EMG, is mentioned, not so much for diagnosing compartment syndrome itself, but as a tool to assess nerve function. It can help differentiate compartment syndrome from other conditions causing nerve symptoms, like nerve entrapment syndromes, for example.
So a picture emerges. Clinical suspicion first, confirmed definitively by pressure measurement, sometimes supported or differentiated by imaging. And the so what of getting this right, as you've really hammered home, is immense.
Absolutely. The sources are very clear on this. Early and accurate diagnosis isn't just important, it's essential. It facilitates prompt intervention and prevents severe long-term complications. The risk of devastating outcomes like tissue necrosis, permanent motor or sensory deficits, chronic pain, it's directly tied to diagnostic delay.
Right.
And reintroducing that statistic, about 32% of claims being linked to delays in diagnosis, just underscores the real-world challenge clinicians face and the incredibly high stakes involved in recognizing this condition swiftly.
That figure really is a powerful reminder of the importance of this topic. Let's move on to management then. Once compartment syndrome is suspected, particularly the acute form, what are the immediate steps according to the sources?
Right. The very first immediate step for suspected acute compartment syndrome is to eliminate any potential external sources of compression. This means urgently removing any constricting bandages, splints, or casts that might be contributing to the elevated pressure within the compartment. Get them off straight away. The affected limb should also be placed at the level of the heart, not elevated, not dependent. Elevation above the heart can actually decrease arterial inflow and worsen ischemia, while keeping it hanging down can increase edema. So, level with the heart is key.
And if pressure measurement confirms the diagnosis, particularly in acute cases, the source points towards surgical intervention, the fasciotomy. When is this necessary, and what exactly does that procedure involve?
Fasciotomy is the primary, often limb-saving surgical treatment for acute compartment syndrome. When the intracompartmental pressure is critically elevated, like that 30 millimil HT threshold or a critical delta pressure, surgery is usually indicated. The sources describe it as a procedure involving surgical incisions made through the skin and the subcutaneous tissue, extending down through the fascia, that tough layer enclosing the muscle compartment. The goal is simply to cut open that tight fascial envelope. This releases the pressure, allows the swollen muscles room to expand, and crucially restores blood flow to the ischemic tissues.
And you mentioned earlier that in severe cases, the incisions might actually be left open initially.
Yes, the sources note that after the fasciotomy, the surgical incisions may well be left open, sometimes for several days. This allows for continued decompression as the swelling subsides gradually. The wound site is then managed with dressings and typically closed later, either primarily with sutures or staples once the swelling is significantly reduced, or occasionally requiring a skin graft for closure if there's too much tissue loss or tension to bring the edges together easily. Postoperatively, patients are very closely monitored for signs of infection or other complications at the surgical site.
Are there specific preparations before surgery mentioned in the sources? Anything particular?
The sources generally highlight standard preoperative procedures, nothing too out of the ordinary. This would include ensuring the patient is nil by mouth, fasting for the required period before surgery, reviewing medications, potentially temporarily discontinuing those that could increase bleeding risk, like anticoagulants, and consulting with the anesthesia team, of course, to plan for managing the patient's pain and physiological state during the procedure is also essential.
What does the typical recovery journey look like after a fasciotomy in terms of postoperative care?
Postoperative care is absolutely crucial for recovery and involves several aspects. Monitoring the surgical site for complications, especially infection, is paramount. Pain management continues to be important, although the nature of the pain might change significantly after the pressure is released. The sources also touch upon the psychological impact. They note that patients may experience emotional challenges, anxiety, frustration, sometimes even depression throughout the recovery process, which can be long. Encouraging relaxation techniques and ensuring access to psychological support are mentioned as helpful. And importantly, physical therapy typically begins relatively early in the postoperative period to get things moving.
Physical therapy seems absolutely key to regaining function then. Can you detail the phases of rehabilitation as outlined in the sources? What does that look like?
Yes, rehabilitation after fasciotomy is indeed a structured process, aimed at restoring function as much as possible. The sources broadly describe it in phases. Phase I typically covers the periods from immediately post-surgery up to roughly 2 to 3 weeks. The primary goals here are protecting the healing surgical wound, managing any residual swelling, and starting to restore a passive and active range of motion in the joints adjacent to the affected compartment. So the knee and ankle for a lower leg fasciotomy, for example. Gentle range of motion exercises, wound care, and achieving a non-antalgic gait that means walking without a limp, often with the use of assistive devices or a special boot for weight bearing, are key components early on. Phase 2 usually starts around 4 weeks post-surgery, assuming the wounds are healing well. This phase involves progressing weight bearing, perhaps moving towards full weight bearing as tolerated by the patient. Strengthening exercises for the affected muscles are introduced and gradually progressed. The sources stress that rigorous or athletic activities should be avoided during this phase and only resumed after specific clearance from the surgeon or the rehabilitation team.
Ongoing wound management and perhaps scar tissue desensitization may also be necessary.
What about long-term care and the overall prognosis for someone who has experienced compartment syndrome? What do the sources say about that?
Long-term care really involves encouraging the patient to maintain an active lifestyle while being mindful of the affected limb, of course, and vigilant for any new or recurring symptoms, especially if they experienced chronic exertional symptoms previously. Regular follow-up appointments with the healthcare team are important too, to monitor recovery, address any persistent issues like nerve pain or muscle weakness, and assess for potential long-term complications.
And how does the timeliness of that initial intervention affect the long-term prognosis, according to the sources? You mentioned the 6-hour window.
This is perhaps one of the most critical points highlighted in the sources. The prognosis is profoundly influenced by how quickly adequate decompression, the fasciotomy, is achieved. The sources specifically highlight that if a fasciotomy is performed within the first 6 hours of the onset of acute symptoms, the likelihood of achieving a significantly better outcome, often with near or complete recovery of function, is substantially higher. And conversely, any significant delay beyond this critical window drastically increases the risk of severe permanent complications. The difference is stark.
What are those specific severe complications the sources mention resulting from delayed treatment?
Well, the sources list some pretty devastating outcomes. Things like extensive tissue necrosis, widespread muscle and nerve death, leading to permanent motor deficits, so paralysis or significant weakness, and sensory loss, numbness. They also mention resulting orthopedic deformities, things like Volkmann's contracture in the forearm where the hand curls up, or clawco, or cavalaris deformities in the foot. These are caused by fibrotic scar tissue replacing the dead muscle, which then restricts movement and distorts the limb's anatomy.
And these severe outcomes must require extensive ongoing management.
Yes, unfortunately, if severe complications occur due to delayed treatment, the sources indicate that patients often face a very long and challenging road ahead. This can necessitate extensive, prolonged physical and occupational therapy, chronic pain management strategies, and potentially further complex surgical interventions to try and address the contractures, deformities, or residual nerve problems, all in an attempt to regain some level of function and improve their quality of life.
Circling back one last time to that statistic about diagnostic delays, it seems to encapsulate the entire challenge you've just described so clearly.
It does, really. That 32% figure is a stark reminder of how crucial clinical suspicion and prompt investigation are. It highlights the need for education and vigilance right across healthcare settings, because the consequences of missing or delaying the diagnosis are so severe and often potentially preventable with timely action.
Prof, that was an incredibly comprehensive deep dive. You've really distilled some complex information into understandable insights for us. We've covered the types, the causes, how the pressure builds, how to spot it, diagnose it, manage it, and highlighted that critical importance of speed. Let's just run through a quick lightning round based on key facts from the source material. Just sharp answers here, if you would. What type of injury accounts for the majority of acute cases?
Fractures, especially long bone fractures.
What's the critical difference in when symptoms appear between acute and chronic forms?
Acute symptoms are sudden and constant. Chronic symptoms occur only during exertion and resolve with rest.
What specific absolute pressure measurement in MA of She is a common threshold for considering urgent surgery?
30 millimeters of mercury or greater.
The sources mentioned the 5 Ps. What's one symptom that might actually disappear late in acute cases, which is actually a dangerous sign?
Pain, as the affected nerves potentially die.
And what is the name of the primary surgical procedure to treat acute compartment syndrome?
Fasciotomy.
Excellent. That clarifies some of the absolute key facts from the material. Now, let's bring it all together into some actionable takeaways for you, our listener, based on this extensive deep dive. First, internalize the risk factors. Whether you're dealing with trauma, sports, certain medical conditions, maintaining a high index of suspicion for compartment syndrome is absolutely paramount.
Second, learn to recognize the distinctive clinical signs. Pay particular attention to that pain that is disproportionate to the injury, pain with passive muscle stretching, and any new onset of paresthesia, especially in those acute settings.
Third, understand that while clinical suspicion is vital, objective measurement of intracompartmental pressure is often needed to definitively confirm the diagnosis and guide the need for intervention, using those thresholds like 30 millimeter HG or the delta pressure.
Fourth, appreciate that time is absolutely critical. For acute compartment syndrome, prompt action, usually surgical fasciotomy, within that crucial window, ideally within 6 hours, is essential to prevent permanent debilitating damage.
And fifth, remember that recovery involves more than just the initial procedure. Rehabilitation through structured physical therapy and proper long-term follow-up are really key components of managing the aftermath and optimizing function as best as possible. That concludes our deep dive into the sources on compartment syndrome. If you found this exploration valuable and enlightening, please do consider taking just a moment to rate and share the show. It genuinely helps others discover this important information. Thank you so much, Prof. Imam, for your expert guidance in unpacking these materials and illuminating this really critical topic for us today.
It was my pleasure entirely. Understanding this condition is absolutely key to making those timely decisions that can have profound positive impacts on patient outcomes.
Indeed. And the sources into the future, too, mentioning ongoing research into potentially less invasive diagnostic tools like NIRS and advanced ultrasound, alongside calls for more studies on long-term outcomes and rehabilitation. This leaves us with a final provocative thought for you. With these technological advancements on the horizon and continued focus on education, could we perhaps reach a point where diagnostic delays become a truly rare occurrence, fundamentally changing the prognosis for this potentially devastating condition? Bring us your next stack of sources, and we'll deep dive into them soon.